Good to meet all y'all. I'm John Rainwater. I'm one of the new care attendings. I have worked with some of y'all very briefly. Um, First off, congratulations on getting to where y'all are right now. This is a exciting time. I know that now that's going to be kind of a purely didactic experience, just here to learn. Hopefully trying to prepare y'all for next year. And again, I know that's going to be a difficult transition. That I was not in your, excuse me, I was in your shoes not too long ago. And so just a brief kind of poll around the room, if y'all wanted to introduce yourselves and share what you're going into next year, just to kind of maybe tailor some of the conversations that we're going to have a little bit more towards what y'all are doing. No, Kelson's going to surgery in California.
Surgery in California. Nice to meet you all, but oh, it's Kelsey.
I'm Alexis. I'm going orthopedic surgery.
I'm Taylor, going into emergency med.
Justine going into PF&R.
I'm Shaylee, I'm going into dermatology.
I'm Sarah, I'm going to OB.
Daniel, emergency.
Alex going into surgery. Emily, urology.
Alex, anesthesiology.
Myra, internal medicine. Myra, internal medicine.
Keen, OB. Blair, psychiatry.
Hudson, radiology.
Jack, urology.
Will, ortho.
Mac, urology.
Spencer, radiology.
Ulysses, thoracic surgery.
Jaffa, internal medicine. Yannick, neurology. Elian, surgery. Ashley, anesthesia research.
Elias, I am. Tim, PBR.
Well, again, congratulations to all of y'all. I heard a few radiologies. I did not hear any pathologies. And I know y'all are going to have to do a categorical or a transitional year. So at some point, you're going to be talking to patients. And kind of the unfortunate reality of what we do is sometimes we have to have difficult conversations with patients. Especially with those folks going into neurology, y'all really kind of diagnose anything good. Like I said, I'm John. Dr. Lloyd, one of our internal medicine faculty, is going to be helping out with the session as well. So I want this to be as kind of interactive as possible. So any questions or anything that I can clarify further, please feel free to speak up. But I hope this will be a fun and interesting session for y'all. And hopefully, like I said, kind of putting y'all on the right foot towards next year. No disclosures. So kind of what I'm hoping to achieve in the next couple hours that we have here is kind of a didactic session for the first portion. So talking a little bit about what we mean by goals of care, kind of surrogate decision making, and then using some kind of mnemonics or kind of helpful frameworks for having some of these difficult conversations. And then a little bit of a break. You'll go get coffee, water, whatever. And then the second session, I'm going to ask for a victim for a little bit of role play. And you guys can observe in this kind of simulated session, kind of play in the sandbox for a little bit, and then kind of see how some of these phrases and frameworks kind of play out in real time. And then a little bit of time to wrap up in questions at the end. So what do we mean when we say goals of care? That's kind of just like a nebulous phrase that gets thrown around, but what does that really mean? Does anybody have any ideas? And have some kind of suggestions? Yeah.
I guess it's I think of it as a checkpoint with the patient to see what their understanding is of what they're going through, and then like how they would like to come out on the other side if possible.
Thanks, very well said. And so how many goals of care are there? And again, I don't need an answer right now, but we'll kind of explore some of these things throughout this presentation. When should we be having these conversations? Who needs to be a part of these conversations? How do I have these conversations? Who should I call an expert? What about code status? It's something that we think a lot about and sometimes perseverate on here in the hospital. And so again, I hope that kind of at the end of this presentation, y'all will be able to talk a little bit more intelligently about these things and be more prepared for next year. So to kind of start things off and sort of frame our discussion for the next little bit, there's a very thoughtful video that Dr. Lloyd actually showed to me earlier this year of Atul Gawande. I'm not sure if any of y'all have read his books. A lot of folks in medicine have. Being Mortal, I think, is probably his most popular one. But he gave a very thoughtful presentation, and this is just a brief snippet. Make sure it shows up. Next one. about how to have some of these difficult conversations.
These are hard conversations. I've blown them many times myself. I've not known what to do. And with this study coming out from the Mass General where the patients had seen a palliative care physician, I realized that the gain they'd gotten was that really they'd seen 6 people who knew how to, that's the staff at the Mass General for palliative care, that they'd seen one of these 6 people who knew how to talk to them about the end of life. And so what I did was I went to those doctors and just said, I'm really bad at this. If you had to make a little list for me of what it is that I should talk about with people facing these problems, what would you put on that list? One of the doctors that I spoke to was a palliative care physician at the Dana-Farber Cancer Institute named Susan Block. And Susan encapsulated it, I thought, the best for me, at least in a way that I could use. She said that there were 4 things that she has as a little mental list in her head that she wants to talk about with a patient who's terminally ill. Number 1, do they know their prognosis? Number 2, what are their fears about what is to come? Number 3, what are their goals? What would they like to do as time runs short? And 4th, what are the trade-offs they're willing to make? How much suffering are they willing to go through for the sake of the possibility of added time? That list was really interesting to me. It was not a list asking, do you want a ventilator or do you not want a ventilator as you come to the end? Do you want your heart shocked? Do you not want your heart shocked? Her point was, if you tell me the answers to those questions, I can make a recommendation to you that says, you would not want this toward the end if these are your goals. Our misconception is that the conversation is about hard choices. Really, it's a conversation about asking people about what they want to look forward to as time runs short and what they fear the most. And the second misconception is that it's that arriving at what we want at the end is a kind of epiphany. Sign here, do you want hospice, do you not want hospice? It's not an epiphany, it's a process. It's a series of conversations and ups and downs as we go through a very hard series of sequence of things that happen to you as you become ill and have things come to an end.
So, Dr. Gwande just kind of concisely did in about 3 minutes what I'm going to spend about 30.
You can make an argument, and I've heard many people say, let me tell you what's going to happen in the future. I think anyone who tells you that should be arrested.
Honestly, that's going to be probably more informative than all this, so I'll just play that stuff out. But no, that I think really encapsulates what I'm going to spend about 30 to 45 minutes rambling about up here. 2 kind of things I want y'all to be kind of playing with in your mind are a couple of things that he said at the end there, which is, 1, this is not an epiphany. These things are, I'm not going to say never because we rarely talk about absolutes in medicine, but it's never kind of like flipping a light switch where, you have this conversation one time, goals are crystal clear, one and done. It's a process. I think the other thing that is important to take away is word that he used for recommendation. Y'all are very highly educated people who just spent the last 4 years kind of studying the human body, the things that go right with it, and what happens when things go wrong. I think y'all are in a very unique position whenever someone who is not educated in those things comes in seeking care. Taking time to understand what their goals are and making a thoughtful recommendation as to how they should proceed and help them to achieve those goals. So again, there's always room for nuance, but roughly speaking, I think there are kind of four broad categories of what a goal of care might be. Any of y'all have any ideas as far as what that might be, or what those might be rather?
And then looking at whether or not you wanna, like, decrease the pain you're suffering when you're about to die, or try and prolong your life, or like,
Yes. Two very good ones there. So goal is comfort. Goal for kind of life prolonging measures, understanding that maybe there's not something that is actionable or curative. There's a couple more. Those are absolutely right.
Like a function or something you want to be able to do.
So rehabilitation, so trying to regain function. And then what would kind of most people's hope be whenever they kind of come into the hospital with an acute issue?
Like curative.
Yeah, exactly. Curative intent. So curative, so surgery for an acute issue, chemo or immunotherapy with curative intent, antibiotics for pneumonia. Rehabilitative, so rehab after acute stroke. I know we've got some PM&R folks in here for kind of deconditioning after a prolonged hospitalization with hopefully something curative. Maintenance are kind of like prolonging measures, as you said. And so what that is chemotherapy with palliative intent, a surgery that is more palliative in nature, so helping to control symptoms. Most radiation therapies, although there is some cancers that can be cured with radiation. And then comfort, as you said. So we are meeting our patients for the first time. What is Tuesday for us is oftentimes these people's one of the worst days of their lives or their family's lives. What kind of information do y'all think we need to know about our patient in order to have our most effective goals of care conversations?
Religious beliefs.
Absolutely. Mhm.
Understanding like their level of function prior to coming in.
Absolutely.
Also their cognitive function and who might be making their decision.
Very good point.
Their understanding of what's happening.
I think that's almost exactly what I have here for our next little bit of the slide. So what I hear whenever I write here, spirituality, religious beliefs, what they're hoping for, who they are as a person, what their personal values are. You need to know somebody's goals and values to help them make the best decision for themselves to help them achieve their stated goals. And so these are usually patient specific. And it's hard to get at. You can't look at a chart and unless, somebody's done a really detailed job of spending some time and really talking to somebody, you can't really peek at a chart and figure out who somebody is as a person and what their goals and values are. I think that is a very important piece. I think the thing that also needs to be present to have our most informed goals of care discussion is, as you said, their understanding of their illness and kind of their prognostic awareness. And so whenever I think about a prognosis, kind of think about it in two ways. So, a lot of times when we think about our cancers, we have a temporal prognosis, or how much time do we have. That can also be shared in the form of a functional prognosis. And so our PM&R folks, when we're dealing with post-stroke patients, kind of what is their capacity for rehabilitation? What are they expected to get back? This prognostic information I have found is usually best coming from the organ or disease specific expert. And I think that's for a couple of reasons. One, usually the patient or family's gonna have some follow-up questions that I think that service is usually best equipped to handle and answer those. I think selfishly as a palliative medicine consultant, whenever we are the ones breaking that bad news, it is sometimes difficult to kind of do an about face and to start going into goals. And I think that sort of having the, for lack of a better term, kind of good cop, bad cop dynamic between us and the primary team kind of helps us to have the most informed, most productive discussions. We need to know what treatment options are available, whatever we have just diagnosed somebody with and how that's going to affect prognosis. I have a guy on service right now who has stage 4 colon cancer. He has a tumor that is, I think, causing impending large bowel obstruction. We were asked to see him to kind of help clarify his goals and fears about whether or not he wants a palliative ostomy creation. I don't think that's going to change his functional prognosis very much. It may help out his temporal prognosis and give him more time at home, understanding that, an ostomy is not something that he prefers. So how do we kind of tease that out and help him to make the best decision for him? Prognosis can change depending on the illness trajectory and any sort of complications that may come up. And again, we have a large database of kind of information to kind of help us prognosticate. So we have these calculators that we can use. So a Cliff C score for cirrhosis, or there's a lot of cancer literature kind of helping to prognosticate for various types of cancers. So it's a little bit easier to determine than spending time talking to somebody about their goals and values. When do you think we should be having these conversations? Early and often?
Like ongoing, maybe even like with primary care providers, like before they even kind of get to the point of needing hospitalization.
Very excellent point. I'm going to come back to that in a second. So I think those are absolutely right. I think that whenever any component in that equation that we just talked about changes, so goals and values typically don't change. However, in the context of somebody's illness, if that changes and that changes what we're hoping for, I think that merits a conversation. Usually we're thinking about a change in somebody's prognosis, be it temporal and functional, that kind of sparks this change. So any new diagnosis, as you're saying, kind of early, an acute hospitalization, I think is a reasonable time to approach this. Times where we're thinking about escalating care to somebody is going to the ICU, or, they have been on a vent for a while and we need to start talking about, is a trach or a peg something that they would want? As you said, ideally these happen in a lower acuity setting where, somebody who has an established relationship with this patient has taken the time to figure out what is important to them. What are they hoping for? I am exclusively an inpatient palliative care doctor. And so usually whenever things are kind of frantic and hectic, and sometimes when we are at that pivotal moment where we need to make some decisions when I see them, it would make my job a lot easier, and I may not have a job if all of these conversations were kind of carried out in the lower acuity outpatient setting. Again, I think taking the time to figure out what is important to somebody to inform these discussions moving forward is a good exercise. In the absence of the above, maybe you won't need to talk about these things. There's one case that I can remember that I'm not going to say doctor or service, but a guy had a debilitating neurologic injury in the setting of receiving cancer treatment. And, family was convinced that he was getting better. He was nonverbal, would occasionally respond to yes or no questions, but family was all aboard the rehab train. I think he's going to get better. He's doing X, Y, and Z a little bit more. He's more interactive. I think he's getting better. And so goals were clear. They were trying to hope for rehabilitation, regaining function, despite our worries that he would probably not be able to get back to a quality of life that he would find meaningful. So I signed off. I got called back about 3 or 4 weeks later because a new attending had come on service, and he said, we really need to readdress goals. So, okay, what's changed? Well, I'm not really sure. So I go and see the patient. He's about the same for me, but I called the patient surrogate decision maker. And she goes, oh no, he's moving his arm more. He is doing X, Y, and Z better. He seems to recognize he's going to come in the room. He celebrated his birthday. He seemed happy about that. And so I can't really attest to whether or not those things were true, but from the family's perspective, the patient was improving. And so I go into this meeting with this other person, and he, shares his worries about the patient's kind of global prognosis. And family goes, yeah, And at about 2/3 of the way through the meeting, they say, why are we doing this? Why are we talking about this? He's getting better. And so I think that maybe necessarily there's some of our rapport with the family, just because, I think I can speak pretty safely for everybody here when I say, like, we want our patients to get better. We want them to achieve their goals and to live fulfilling lives. Unfortunately, because of their disease processes, that often doesn't happen. But I think it's important to kind of be your patient's best advocate and best cheerleader. And I worry that interaction maybe damage the reputation a little bit. So who needs to be in these conversations? Somebody over there, I can't remember who exactly it was, but said, somebody's family or their surrogate decision maker. Who all else do you think needs to be involved? 100%.
Maybe ideally a member from each team of whoever's taking care of the patient.
And so I think with Alex, he mentioned spiritual support. Basically, whoever the patient feel like needs and wants to be there. So I think somebody brought up, what if my patient can't participate? So I'm going to spend a little bit of time here kind of talking about surrogate decision making, just because I think that is something that you're necessarily going to run into as you start to practice here. Keeping an eye out on the chart for any sort of advanced care planning documents that they filled out, say things like an advanced directive, naming a power of attorney, a living will, things that they absolutely would or would not want done when it comes to their medical care. And, if it's a case of a patient who has advanced dementia, is not able to communicate, I think that it's very unlikely that they'll be able to meaningfully participate in their care moving forward. But if somebody has, sorry for that question.
Yeah.
Please.
You mentioned the living will.
Yes.
I just came off my IC rotation. There seems to be like a lot of how valuable is the living will? How valuable is the living will?
Yes. Hold on to that question. I will talk about that in just a second. But and I know Dr. Lloyd can probably, as a member of the ethics committee, Dr. Lloyd can, I'm sure kind of share a little bit more about that in a second. But that's a very good and thoughtful question. It's something that I run into in my day-to-day practice. So thank you for asking. But, if a patient is on the ventilator and, we're expected that they might be able to be extubated in the next day or so, maybe we hold off on these conversations until they are able to participate. Likewise, if somebody has hepatic encephalopathy and we give them some lactulose for a couple of days and they come out clear on the other end, then maybe they can participate. So I have the North Carolina decision-making hierarchy here. So as you said, preferably our patient is the one that we're having these conversations with. Next, kind of down the list will be their healthcare power of attorney, a legal guardian, and then a general POA. Next would be patient's spouse, and then a majority decision among the patient's parents and children over 18. Then you fall to, if these people are, not available or deceased, then it would be their reasonably available siblings over 18. And then it would just be an established relationship with the patient who seems like they're acting in the patient's best interest. And then, if we have exhaustively searched and have not been able to turn up anybody, then it would just go to the attending physician by default. So just some considerations here. There is a case that we were talking about on the ethics committee where somebody's kind of legal next of kin in the sense that they didn't have any other family that we knew about, but they said I'm their power of attorney, but she was unable to produce the documents. And so I think taking everything with a grain of salt is important. And so until they actually produce those documents, you kind of need to follow the letter that you see here. I will say that this is exclusive to North Carolina, and different states have different hierarchies of surrogate decision making. So, if we drive 45 minutes south into South Carolina, spouse is still at the top of that third rung there, but then I believe that it is children first and then parents and siblings together. And then when I was in Alabama doing my palliative medicine fellowship, the age of, not consent, but like the age of being considered an adult is actually 19. And so an 18-year-old here could be somebody's surrogate decision maker, but not in Alabama. Something that is also important to consider, depending on where you practice, is kind of common law versus legal spouse. In Alabama, you can kind of get grandfathered in if you were deemed somebody's like common law spouse before like 1990 something. But after that time, that doesn't really have any legal bearing. And then legal guardians can be logistically challenging endeavors. I'm not sure if any of y'all kind of like on your sub-Is or anything have had to work with somebody who had a legal guardian before. So basically, that is a situation where somebody doesn't really have a person who can act as their surrogate decision maker, doesn't want to act as their surrogate decision maker. And so, the judicial system assigns someone to act as their surrogate decision maker. You're communicating usually with like a case manager or a social worker the majority of the time. And then any kind of big changes in their care, you have to, fill out a form, fax it over. And so talking about big changes in care, so things like code status, decisions to refer to hospice, which again, this is a partially state dependent thing. Like in North Carolina, the case managers or the legal guardians can make those decisions. In Alabama, interestingly, even though somebody has a legal guardian or a power of attorney, a legal guardian, they can't make decisions about de-escalation of care. And even the family does not have any kind of input on their day-to-day care. They're the ones who have to make that decision, which I thought was interesting. So I've got pulled up here. I'm sure y'all seen that before. That is a goldenrod called a portable DNR. So I have an example of kind of the North Carolina power of attorney form. So designation of healthcare agent. So this is just saying who you would want to be your surrogate decision maker. And so this is kind of getting into the living will exercise, which is kind of very limited. Yes or no. Do I want a feeding tube? Do I want artificial nutrition and hydration? Do I want to be on a ventilator? Things like that. And so the other form that I kind of think about is a most form. So this is the pink sheet. I'm sure y'all have maybe seen some of these on your rotations before, but it is kind of like, I think of it as a framework for somebody's care in the sense that or in the event that they are not able to reach somebody like a surrogate decision maker. And so again, still some kind of, how do I say this? Still kind of like in kind of discrete boxes or areas, but there's a little bit more room for interpretation. And so, DNR or attempt CPR, full scope of treatment, limited or comfort measures. Antibiotics, again, there's this determined use of limitation or antibiotics when infection occurs. So it gives you a little bit of latitude there. IV fluids for a defined period of time, feeding tube for a defined period of time. And, the patient is not necessarily the one who has to fill this out. If they are incapacitated, somebody surrogate can fill this out on their behalf. Two things kind of thinking about these forms. These do not override what the patient who is sitting there talking in front of you is saying. These are kind of in the event that they lose capacity. And these things can be changed. To answer your question about, how valuable is a living will, I think of it more, and if I'm wrong, Dr. Lake, please correct me. I think of it as, ideally kind of like a helpful framework, kind of like an advanced directive. So like if somebody is acting in somebody's best interest and they had said previously in the like, hey, I would not want to be on a ventilator, I would not want to receive a feeding tube, then you would hope that somebody's surrogate decision maker would honor that. I think that and I spent a little bit of time researching this, I think there are some times where somebody's surrogate decision maker, their power of attorney, can override some of the directives in their living will. Right, Dr. Lake?
Yeah, I mean, it's it's a nice way to, it's a way to help the surrogate kind of understand their decision-making process, because they're supposed to be making decisions based on their stated wishes, but oftentimes the living will doesn't really, it's not very situation specific. Then additionally, it can be written, at a time where the patient's values were in one state, then change maybe over time, and the surrogate will often kind of say, well, we spoke since then, et cetera, et cetera. So it's hard to override a surrogate's decision-making, but it can be a way to kind of focus them on the patient's desires. I don't know if that's what you researched as well.
I hope that answers your question. So I guess the short answer is sometimes not very helpful or not very useful. So, we've got everybody in the room. The gang's all here. Now what? So what you were saying earlier was, ideally primary care doctor, kind of a lower stakes setting. We've been able to have these conversations. I tend to think of these things, when I'm first meeting somebody, ideally it is not like this big kind of daunting meeting where everybody's kind of crammed into a conference room or in the patient's room. You've got a chance to sit down and get to know somebody beforehand. So I kind of do what I like to call a palliative needs assessment when I'm meeting somebody for the first time. And so, like I said, getting at them, exploring their goals and values, not necessarily in the context of illness, but, what makes a good day good for them? What are they looking forward to after leaving the hospital? Who are their people? Not just their surrogate decision maker, but who are their family and their forms of social support? Kind of broad strokes. What is their understanding of their illness? What have the other doctors been telling you? What do the doctors seem worried about? I think that whenever I go and see somebody in consultation here in the hospital, I really don't have a game plan unless something is very, very acute. I mostly just want to get to know people. My goals for the first meeting with somebody are twofold. One, establishing a positive relationship, being a positive presence during their hospital stay, and gaining trust and building rapport. I think that is a helpful exercise to do when you're first meeting somebody, because if the worries that we have about their kind of healthcare trajectory come true, we'll kind of bank some of that positive rapport. And so whenever it is time to make a decision, you kind of have some cachet build up to make a best recommendation for them. I will say that, the palliative needs assessment, or just getting to know somebody, you're not really addressing goals of care. You're just figuring out who they are and what they're hoping for. So there are some mnemonics or frameworks that I think are very helpful when starting to do this, to kind of keep things organized in your head and kind of keep a natural flow going through these conversations. And so spikes is a framework that you see up there that I think of as the kind of roadmap for helping us to deliver difficult news to a patient. So setting, P is perception, I is obtaining an invitation, K is knowledge, E is empathy or expecting emotion, and then S is strategy and summarization. So setting, I think, is not just the physical setting, even though I think that's important. That's making sure that everybody who needs to be there is there. So that's the patient ideally, or their surrogate decision maker, any other forms of social support that they want there. Picking a place, sometimes like a busy ICU room is not the best place to meet. So oftentimes we'll try to find a conference room or going to the chapel to have these discussions rather than kind of in the room, especially when something acute is going on. I think setting is also setting your expectations for the meeting. And so I usually like to give a summary statement saying like, hey, John Rainwater, I'm one of the palliative medicine docs. I really appreciate y'all coming here to help us figure out how to take care of your dad since he had this stroke. Just kind of setting the tone for the meeting moving forward. And then knowledge is after you have set up why we're here, make sure that everybody's there, figuring out what their understanding of their illness is. The P is the most important part of spikes. Just because, whenever we're thinking about somebody's prognostic awareness, if somebody comes in, paraplegic after a acute injury, and they tell me the next week their goal is to run the Charlotte Marathon, that's probably not realistic. And so making sure that they have a good prognostic awareness is going to be pivotal in make sure that you have your best conversation. So the knowledge and sorry, going back to the I, obtaining invitation for the patient, that is kind of a strange phrase, but I think that that is important for a couple of reasons. So one, by invitation, I mean, hey, Mr. So-and-so, I hear what you're saying, and I think you've got a good understanding about what's going on. Would it be okay if I shared one of my worries with you? I think that kind of accomplishes two things. One, lets the patient know that we're kind of going to shift the paradigm a little bit. There's going to be a tonal shift in our conversation. Two, I have seen several cases where a patient or a family member may be upset because they say, like, you know, somebody came in here from oncology or surgery or whoever, and, you know, they just told us my dad has cancer and they left. I think that at least on a subconscious level, kind of getting somebody's permission to share some of this bad news allows them to process it more easily. And I think kind of prevents a negative relationship occurring after they give you that permission to share your worry. So the knowledge, I think, is usually shared as a headline. Has anybody heard that term before or used that before in their kind of discussions with patients or families? So by headline, I mean usually a kind of like concise, for lack of a better term, like punchy phrase, trying to distill what your worries are for this patient. I think that I have a little bit more in the R section of remap, but it is a statement to let the patient know that things are different and why we're having this conversation. And so I usually say in the form, and again, it doesn't necessarily have to be this formulaic, but I say something to the effect of, you know, Mr. Smith, you know, I worry that despite all of the treatments that you've received for your cancer, that they're not working, and I'm worried the time may be short. I think that it's important to acknowledge kind of what somebody has been through and phrasing it as an I worry statement instead of like a definitive statement. I think for a couple reasons. One, like we said earlier, there are no absolutes. And I think that saying that you worry kind of lends credence to the fact that you're an empathetic and caring person, that you are worried about them and you still do want the best for them. So after you deliver this headline or kind of share this news, your instinct will be to keep talking and to say, you know, X, Y, and Z, we've seen Q lab value going up, you know, we're worried the time is short. After you deliver that headline, I want you to fight that instinct and to say absolutely nothing. And let the patient and the family be the first person who moves in silence. Usually, it is going to be some form of emotional response, you know, whether that is anger, whether that is sadness. I think that it's important to address that underlying emotion, and we're going to use another framework and a mnemonic to kind of walk through that in a second here. After you've spent some time addressing that emotion and unpacking that, spending some time summarizing what you said and trying to, you know, shift things towards kind of like the creation of a plan. And again, spikes is a mnemonic for kind of just breaking the bad news. Remap, I think there's a place for spikes in remap, and I know y'all haven't seen that yet. But remap, I think of as more for after you've delivered this bad news, how to create a plan for somebody and to make your best recommendation and help them achieve their goals. So remap, reframing, kind of like the K in spikes. Advising the patient while we're having this conversation, new prognostic information, be it temporal or functional, the headline like we talked about. Let's say, you know, you've got everybody together, you know, oncology, surgery, primary team. You share your worry with the patient. It could be that that's the end of the meeting. Anecdotally, and I'm sure y'all have maybe seen this in practice, If you tell somebody, ideally in the clinic, they have cancer, they're not going to remember anything else that you say to them after that word. And so I think being respectful of where they are, kind of in their processing, is important. And so that may be all that you get done for that meeting, and you need to kind of pick it up later on. As Dr. Iguande said, it's not an epiphany, it's a process. So after we've reframed, kind of like the E and spikes, the same thing, you want to expect emotion. And so there's another demonic called nurse that I'm going to spend a little bit of time talking about to kind of help you come up with a framework for addressing that emotion in kind of a comprehensive way. Something that y'all have probably come across in your training or your sub-Is or your rotations, and you may not have realized this, is the difference between an emotional or a cognitive question. Does anybody have any idea what I mean by that? So once you are kind of aware of this, it's kind of interesting to see this play out in real time, but there will be somebody who is already kind of in an agitated or an elevated emotional state, and they will ask you a question about treatment or prognosis or some facet of their care, and you will answer it with a number or a fact or data, and that doesn't seem to give them what they want. They continue to remain elevated. Sometimes they get more upset, and you kind of just keep building and building and building until something happens. What you're seeing is not really a cognitive question. They do want data, but not in that acute moment. I think that it's important to kind of address the emotion underlying that. And I have seen anecdotally, somebody's here and they say like, why didn't anybody call me to let me know about this result? I could have come in a week earlier and gotten treatment for my cancer or something like that. And instead of saying like, well, a week really doesn't matter that much. It's at the end of the day, it's probably not going to change anything. It's not what they want to hear right now. I think it's important to acknowledge that emotion. Say like, hey, Mr. Smith, I can tell that this is really frustrating. There's a lot of gaps, unfortunately, in our healthcare system sometimes. How can we take the best care of you right now? And you will notice that the emotional tension in the room comes down. After you have addressed that emotion, it's important to map things out. And so this is exploring somebody's goals and values in the context of that new prognostic information. Again, hopefully you have beforehand spent some time getting to know somebody and figuring out what their goals and motivations are for this. Aligning, kind of like the second S in spikes, a summarization. And so a summary statement of what they're hoping for. And so, you spend some time talking to this gentleman who was recently diagnosed with cancer, and you say, Mr. Smith, I hear you say that, the most important thing for you in the morning is being able to, drink your morning coffee and, watch your dogs play in the yard. I'm not sure if those are the things that are most important to you, that a thing like a feeding tube makes sense. You won't be able to enjoy your coffee that way. Again, that's a little reductive, but something to that effect. And then plan a patient-centered recommendation in light of the above information. And so if somebody's goal is to maximize time at home, they hate coming to the hospital, they don't feel like it's a helpful place for them. They feel like, doc, every time I'm coming in, I'm getting a little bit worse. I just want to spend time at home with my family. I think that, like I said, y'all, as people who are going to be doctors here in a couple months, and treating patients independently for the first time, like I said, y'all have, I think, the bona fides to be able to make a recommendation, as long as it's a patient-centered recommendation and really taking into account their goals and values. That is something that took me most of residency and honestly a little bit into fellowship to feel comfortable making that recommendation. And y'all are not going to come right out of the gate screaming and doing this. It's going to take time to kind of build that confidence. But I want y'all to feel empowered to be able to do that whenever y'all feel ready. And so here, just kind of some examples of the different parts of rehab. You've worked very hard with all the treatments over the years, and now that you're feeling more tired and it's harder for you to do the things you enjoy, I'm seeing that you're in a different place now. Further treatments may be too hard on you. I'm addressing the emotion. What worries you about this? If somebody's crying, I can say that I can tell that you're sad. Tell me more about what you're thinking. Mapping out, again, What are the things that you enjoy? Given that time is short, what are the things that you are hoping for? Aligning, kind of like that summary statement. From what I'm hearing, the most important thing for you is time at home, sitting on the porch with your family. You feel like at this point you spent too much time in the hospital and you wouldn't want to come back if it only would extend your life for a matter of days or weeks. And then proposing a plan. Given what you told me, I propose that we do, sorry, the clicker's annoying. I propose that we do everything to help you spend time at home with your family. I don't think more cancer treatments are going to help you with that. I think getting hospice involved would be able to help you maximize that time and quality of life at home. So these are not really things that I've seen kind of in textbooks per se, but just kind of some rules that I picked up in practice and in training. Again, like I said, the invitation and the knowledge and spikes is the same thing as the R and remap. Asking for permission and giving a warning shot, like we said. Making sure that the setting is ideal prior to sharing this. Again, making sure that the patient has their support system there with them. There was a case that I saw not too long ago of a patient who was non-English speaking, who relied very heavily on her English speaking daughter to help her make decisions. And patient's primary oncologist came in to discuss their prognosis with them. And again, that was the person who should have been sharing that prognosis. Daughter was not there physically and was there over the phone. And the daughter, for the rest of that patient's hospitalization, was very upset with the cancer team because she was not there when her mother received that news and that she was all alone after that. I think the other thing to consider is, again, making sure that the right people are there. It's also making sure that the wrong people aren't there. And so it's kind of our instinct whenever we go into a room and patient has visitors like, well, they're visiting in the hospital. Of course, they are okay with sharing medical information with them. Always want to ask and make sure that you get somebody's permission before you do that, especially when you're talking about sensitive stuff. And so I'll always ask people, it's like, hey, I assume this is the case, but are you okay if we talk about medical stuff in front of X, Y, and Z? 99% of the time they will say yes. And then, if I think I'm going to talk about stuff that is a little bit more sensitive, so things like, substance use in the past. I was like, hey, we talked about stuff that I know that you struggled with in the past. Are you absolutely sure that I talk about this in front of, your mom or your sister? And I think that's a good idea. There are some little things that you can do that I think are going to help you build rapport and a positive relationship with somebody. Especially when you're delivering bad news, kind of standing over somebody and leaning over them, even though it doesn't change how you deliver it or what you're saying, just taking the effort to, get down on somebody's eye level, sit down, squat, meet them where they are, I think does a lot subconsciously for somebody. And then a lot of people would recommend this. I don't do this, but it's a good exercise, is before you go into a room and before you meet with somebody, talking with, your attending or the other team, what are the goals for this meeting? What do I want them to walk out of this meeting knowing or understanding about our worry? And so some people will write down a headline and will, come up with several different drafts or revisions for what they want to share with the patient, or what is the one thing that I want them to take away. I usually phrase it as an I worry statement, despite, X, Y, and Z, I worry that we're going to see more complications related to your disease, or I worry that time may be short. There is a very helpful video from the University of Wisconsin Palliative Care detailing a best case, worst case scenario. And so I found this to be kind of a more helpful exercise when it comes to like surgical cases. So, we offer this intervention. Best case scenario, we have, you being able to leave the hospital, go into rehab, and then maybe being able to go back home. Worst case scenario, we're looking at in-hospital mortality. I think that this is a helpful exercise for a couple of reasons. One, kind of giving somebody the range of outcomes and sharing with them where you think on that continuum fall. I think that the other thing is, if the absolute best case scenario for this intervention or this hospitalization would not be acceptable to the patient, I think that merits a shift in what our goals are. So, if somebody had said that under no circumstances would they want to live in a nursing home, that is not a meaningful quality of life for them. And the absolute best that we will be able to do is the rest of somebody's life in a nursing home. I think that we maybe need to shift our goals up here. like I said earlier, after you deliver that headline, fight that instinct to keep talking. I once, I delivered a headline and I wish I had had a stopwatch on me, but it had to have been at least 3 minutes of just nothing but silence. It does get obnoxious after a certain point. And so what my attending recommended to me when I was in fellowship was, whenever you think it's been too long, count to 10. Wait a second, count to 10 again, and then you can talk again. And then, like I said, expecting that emotion. So nurse is kind of like that framework that we were talking about for addressing that emotion. So naming it, saying that, hey, I can see that you're upset. I can see that you're sad. Tell me more about that. Or I can understand that you feel angry right now. And actually, I broke my own rule there. I would avoid using the word understanding because at the end of the day, we're not going to understand what somebody's feeling and what they're going through. You can say I can imagine or I can empathize, but understanding, I think, can lead to, most of the time people will respond positively or neutrally to that, but you will occasionally get somebody saying like, no, you don't understand. You'd have to say, you're absolutely right, I don't. Respect. So something to the effect of, I can tell this is hard on you because I know you have worked so hard to go to all of your appointments, receive all of your treatments. I just want to commend you for that. Support, and so providing opportunity. So something to the effect of, we're here for you. We want to help you come up with the best plan for you moving forward and exploring that emotion. So, usually emotion is response or overlying something. And so most of the time it is, understand why if you go to somebody that they have cancer and they're sad, that's reasonable. But if somebody has an unexpected emotion, exploring kind of, hey, I see that you're, very angry. Tell me more about what you're feeling. The one thing I would say with the caveat with the respect statement is only use it if it feels genuine. If somebody comes in with their mom or dad and they've got stage 4 wounds, they've got an active APS, report out on them, I wouldn't say something like, I can tell you've been taking really good care of your dad, because that's not genuine. So maybe come up with something else to say in that instance. So we share the difficult news. We've addressed emotion. Now what? Like I said, that could be all that you do that meeting. Make sure that you take the time to address that emotion. And it could take multiple meetings to fully elicit their goals of care. And then if they are amenable to proceeding, you can start to map things out like we were talking about through map. These are just some helpful questions. So have you completed a living will? What is most important to you? As you think about the future, what's concerning you? What are things that you're worried about? What do you want to avoid? What do you like to do when you're feeling stronger? Their experience with their medical intervention. So how has chemo been for you? How has radiation been for you? I think that is a very helpful exercise, that penultimate one, family and friend experience with medical interventions. A lot of people know people who have been through similar stuff. And so just spending a little bit of time and asking them about, my mom died on the ventilator when she was in the ICU, and that was a really scary thing to go through. I don't think I would want that for me. Or, my mom was on hospice and it was a really good experience. She was able to go at home. She was comfortable. She spent time with her dog. I think that's something that I would want. And so people aren't really thinking about those things in the context of their own illnesses because they are reasonably preoccupied with what's going on with them. But ask them to take a step back and think about how these things being done for other people make them feel. And so these are just some examples of mapping questions that are not in those frameworks, but if somebody is not really answering the questions that you want with that kind of those conventional ones, kind of trying to backdoor to understand what their values are is helpful. So what are the things that give you strength? What does a good day look like for you? What's something you feel like you couldn't live without? I don't really like to use the phrase quality of life unless the patient brings it up. But if they do, say like, hey, quality of life means different things for different people. What does that look like for you? I'm not going to get too deep into the religious or spirit kind of spirituality angle, but Somebody will say, well, I'm hoping for a miracle. Well, what does a miracle look like in your mom's case? Or what does a miracle look like in your case? Sometimes it is not as, far-fetched as they would usually believe. For some people, a miracle may be being able to walk again after a stroke, but for other people, a miracle may be being able to spend more quality time at home. So I think some time spent exploring that instead of just immediately dismissing it is a good idea. Again, these are just some pearls for mapping. It's going to be the most time-intensive portion, but I think it's the most important so that you're making your best recommendation for the patient. Always be curious and inquisitive. Ask the patients what they're considering whenever they ask a question of you. So, say like, well, doc, sometimes it's like a simple cognitive question, where do I go after this or how much time do I have? But usually there is something that they're thinking about whenever they're asking these things. And so somebody asks like, do you think I'll still be here in 2 months? So that's a really good question. I don't know, but tell me what you're thinking about. Well, my daughter's getting married in June, and I really want to miss that. I don't want to miss that. So maybe that could color your recommendation for how to best care for them moving forward. And then, like I said, making sure that the things that are important to them whenever you are making your recommendation to help them in the future. So, like I said, I've spent a little bit of time talking about the aligning and planning part. Let's say, you spend an hour mapping things out. You feel like you got a super good understanding of what their goals are, what they're hoping for moving forward. And you say, Mr. Smith, because of X, Y, and Z, I recommend that you go home with hospice. If you did your job right, most of the time, they'll say, yeah, that sounds good to me. That seems reasonable. Sometimes they'll say like, no, doc, you got it all wrong. That's not what I want at all. And so I think that spending a little bit more time, maybe you missed something important when you were mapping and they'll usually tell you what that is, or maybe they don't have as good of a sense of the prognosis as you thought originally. And then being cognizant of somebody's social resources whenever you are making a recommendation. A situation that I kind of run into a lot personally is, somebody wants to receive hospice care, but in order to receive that as well as care in a skilled nursing facility, you need 2 types of insurances. And so I can't really recommend skilled nursing facility with hospice if they only have insurance payer. Or, somebody wants to go home with hospice, but it is their elderly debilitated spouse who would be the only person with them 24/7 and they have a lot of care needs. I don't think that I could reasonably recommend home with hospice just because I don't think that would be the best setting for them, even if that's what they want. So you did everything right. You did everything perfectly. Goals are not clear. What do you do then? I think that's a reasonable time to get us involved. Whenever goals are not clear after sharing your prognosis, there's complicated family dynamics, or if you just feel like you need help. At the end of the day, that's what a consult is in the hospital. Asking another doctor, another team for help with something. And there's just things about consult. There are things that you can do to make a consult better. So follow good consult etiquette. So, if I called Dr. Dunn for help with somebody's diabetes and, I haven't gotten an A1C or checked like their C-peptide, she, I think, would be a little miffed about that. Or if I called Dr. Leonard for an infectious disease question, I haven't gotten any blood cultures or started them on raw antibiotics, he would probably wonder why I didn't do those things. And so I think that at least making an effort to have some of these conversations on your own, or at the very least, kind of figuring out who the players are, what the family dynamics are, just to help us make the best recommendation and help to take the best care of the patient after we've been consulted. I would make sure that either you as the primary team or the appropriate service has shared candid prognostic information with them. I personally don't want to get into a situation where, a patient's not a candidate for, valve replacement surgery in their heart. And I go in there and that's the first time that the family's heard about that. And they say, well, why can't she get a mitral clip? So that's a great question. I don't know. Let me call the cardiologist. They can come and talk to you about it. That's not my news to share. Our job is to clarify goals of care, and it's not to change somebody's mind or convince them to not want something that is being offered to them. See Dr. Lloyd grinning back here. If you don't think that coding somebody would be a helpful exercise, I think you need to share that worry with them. But at the end of the day, if that is something that you or your team is willing to offer, then the patient is absolutely welcome to take that. And speaking of code status, this is my last thing, guys. I know I've taken up a lot of y'all's time. I think of code status as a very small part of somebody's overall goals of care. And so whenever I have this conversation with somebody, again, I was a fresh intern once, and I would go up to somebody and say, hey, you know, in the event that your heart or your lungs were to stop working, would you want us to do things like put you on a breathing machine or do CPR? Or, do you want us to do everything that we can to keep you alive? Most people are going to say, well, yeah, why wouldn't I want that? And then, I would go to 201 and say like, oh, but CPR, sometimes if we do it right, that breaks ribs, or, the shots can be painful. And they would say like, oh, I don't know, but I think I still want to stay alive. And so I think how you frame it or how you phrase it can get you a different answer. And so instead of saying, would you want us to do everything to keep you alive? One of my VA attendings when I did fellowship, I stole this from her and I use it all the time. But, so she'll go up to a patient and say, a lot of veterans that I talk to, they have strong feelings about things like artificial life support. Have you ever thought about those things before? And that will kind of get you back into what we were talking about earlier, where it's saying, well, my mom was in the ICU and she died on the ventilator, and gosh, that was scary, and I don't think I would ever want to go through that. I think that you could very reasonably rate the recommendation, especially when you feel like you're worried about somebody and how their hospital stays. And it's like, hey, if that's how you feel, then I would recommend that we don't do those things. And if we did start to worry that you were going to die from one of these things, that we just focus on making you comfortable. Again, they'll tell you if you got it right. And then, like I said, setting is important. You're on your sixth admit of the night at 3 a.m. You're not going to have a super in-depth goals of care conversation or code status. Sometimes you just got to put something in a chart and let the day team figure it out the next day. Again, unless things are very, very acute and it's very necessary that you have that conversation at that time. And again, you can make a recommendation. So how do we feel about these questions now? Hopefully a little bit better. Any questions for me or anything that I can clarify? I nailed it. Did it perfectly. Well, let's take a quick break. It is 10:08. Let's get back here at 10:15. I spent too much time